Hello, my name is Naveen Pemaraju, Associate Professor in the Department of Leukemia, MD Anderson, Houston, Texas. I'm joined by my colleague, Dr. Marina Konopleva, Professor in the Department of Leukemia at MD Anderson. Today, we will bring to you panel number 2 discussion, which is on It Takes a Team, the multidisciplinary approach to treating our patients, diagnosing and managing those with blastic plasmacytoid adnexal neoplasm, or BPDCN. Marina, as you and I have been discussing throughout the last several years, it really takes a village, a real team approach to treat patients with this rare and complex diagnosis. You and I have been used to, in our practice, really being the captain of the team, managing most of our patients in the hem-onc clinic. But as you and I have noticed, patients with BPDCN really need more personnel, more doctors involved. I wanted to see if you could take us through some of those key team members that you use at our academic center and that you would recommend for those in community practice.
Thank you, Naveen. As you pointed out, our mode of action really has changed with the BPDCN patients, which came to our clinic a few years ago and now becoming more and more frequently with this recognition of the disease and novel therapies available. So I would like to take you through just a few key people we have been working with over the last few years and advise our colleagues in other centers how to best deal with this complex disease. So the first person I would like to point out who is extremely important is a hematopathologist, because BPDCN is histologic diagnosis and it requires really the expertise of the very experienced hematopathologist who knows all the markers, who needs to do additional stainings and has to recognize and differentiate BPDCN from other malignancies such as AML and ALL. And we would probably advise that if you are working in a smaller center which doesn't have necessarily the specialized hematopathologist, the best way would be to send the pathology of your patient into the specialized center to make sure it is confirmed the diagnosis, because this is critical for the further treatment and indication for transplant as well. The second person who was very essential in our practice is dermatologist, because skin presentation of BPDCN happens in the majority of the patients. And it is not only the skin involvement, but is the extent of the skin involvement which has to be quantified and it has to be assessed longitudinally as a response to the therapy. In addition, BPDCN requires biopsy, and the skin biopsy is extremely helpful to diagnose BPDCN with the help again of hematopathologists. Therefore, we have the dermatologists part of our team practice, and they have been assessing our patients longitudinally along with us, with our team, to follow up on response, to make sure if there's any residual disease, which is again confirmed generally by the biopsying the residual lesions, if any. And finally, the next person who has been essential for our treatment of BPDCN patients is a stem cell transplant physician. We all know that BPDCN is a hard-to-treat disease. It has very poor prognosis, and as of right now, stem cell transplant remains the standard of care as a consolidation after induction therapy, which is most commonly right now SL401. We generally prefer allogeneic stem cell transplantation as the best curative approach for our patients, but there are not all patients that can undergo allogeneic stem cell transplant. In particular, the old patients sometimes cannot go through that. Therefore, there are some data that autologous transplant can also be helpful in BPDCN, possibly with skin-only disease, and definitely in all patients, and that provides additional consolidation approaches and extends the survival. Therefore, we always consult the stem cell physician before we start even treatment to identify the donor to facilitate the route towards allogeneic stem cell transplant if that's considered to be a next step, and also as an assessment after we administer the induction chemotherapy.
Wow, thank you very much, Marina. That was a really helpful approach, both in the academic and in the community setting. You highlighted several key things, and the only things to add to that for our colleagues around the world is the importance of nursing and advanced nursing, or so-called advanced practice providers or physician extenders. As you and I know, we've found those team members to be essential to our care. Now, not every clinic will have that, but I think our patients with BPDCN have some special unique needs, particularly the compartment of the skin, as you mentioned, which is a bit unique for most practices in the hem-onc setting that deal with blood cancers. So we try to involve our nursing colleagues and the advanced practice providers, both at the education at baseline for a rare disease and then monitoring of the skin and other compartments. And then finally, as always, of course, you and I for our center is access to and education about clinical trials. Now we have the one approved agent, the tagraxofusp for SL401. We have some standard off-the-shelf chemotherapies, and you and I and others are leading further clinical trial efforts. So anytime someone has a rare disease, rare cancer, we always, Dr. Konopleva and I and our colleagues, always advise access to education and awareness about possible clinical trials that may be of benefit to you.
Absolutely.
So with these thoughts for our colleagues around the world, we'd like to close by reminding team members that there are so many people who are helpful in the diagnosis, management, and treatment of patients with BPDCN, and we encourage you to find out those resources in your community or to refer to an academic center. So thank you so much for your time and attention, and good day.